Today we'll talk about a pathology that we see frequently in the proctology office, and that is the pathology of a rectal prolapse. Now, usually when individuals have a rectal prolapse, they come in complaining of something coming out of the rectum, and if it's been going on long enough, it happens spontaneously, but most often it happens when they're trying to defecate. Often it goes back within the rectum by itself, but occasionally individuals will come in and say, I have really bad hemorrhoids. They come out when I'm utilizing the restroom, and then I have to push them back in. With that kind of a history, it is difficult to diagnose exactly what's going on unless you're able to visualize what exactly is coming out. And upon visualization, you can then tell if it's internal hemorrhoids that are prolapsing, or if this is a partial thickness rectal prolapse where the inner lining, the mucosa of the rectum is prolapsing, or if it's a full thickness rectal prolapse where the actual muscular wall of the tube of the rectum is prolapsing outside of the rectal vault. Now, it's very important to know which one of these three it is, because they're all treated very differently, and while they're inside the body, they're normal. That's a normal part of anatomy to have all this tissue within the body. It's only once it's prolapsed out and you see it while it's prolapsed out that you can tell that this is abnormal and this is the part that's coming out, and then provide appropriate recommendations to the patient as to what the risks associated with each of these prolapse entities are, and what to expect as far as management and outcomes. Often we would have to have the individual do a Valsalva maneuver within the commode to observe the prolapse itself, or sometimes the individuals, if they state that the prolapse happens occasionally, can actually take an image of the prolapse tissue and bring that in for examination. Now, once we know which one of the three entities it is, assuming that it is a full thickness rectal prolapse, we recommend having it treated. And given that this is a structural abnormality within the body, the treatment is surgical. And the treatment for a full thickness rectal prolapse is a standard treatment is a rectopexy, where we go through the abdomen and pull the rectum and tether it to strong tissue overlying the front part of the fascia of the bone, and this prevents the tube of the rectum from sliding out and prolapsing. We may or may not also recommend having a portion of the colon taken out at the same time, depending upon what the underlying etiology of the prolapse is. For the most part, there are two factors that cause a prolapse to happen. The first is that there is some underlying pathology that's causing a physiology where the individual is having significant intra-abdominal pressure, and that may be severe constipation. It may be that the individual's heavy weightlifter, not utilizing appropriate techniques sometimes, or it may be that they have a severe chronic cough, which is causing intermittent bouts of significantly high abdominal pressures. To go along with it, there's got to be a weakness of the tissue, of the connective tissue of the rectum within the pelvis. So depending upon what the etiology is, we can make recommendations to minimize the intra-abdominal pressures in the future to allow the repair to last longer, and give the individual a much better quality of life. If individuals do not have a rectal prolapse repaired, then they tend to have issues with recurrent urinary tract infections. They can have issues with hygiene of the skin around the anal canal, with potentially recurrent infection in that area. And over a prolonged period of time, they can also develop issues with fecal incontinence. So for all of these reasons, an individual with a rectal prolapse needs to be appropriately examined, appropriately guided, and then treated.